So to begin with, you guys, thanks so much for being accommodating and meeting me over Zoom tonight. I had a glitch and I just wasn't able to leave my house because I didn't have a sitter for my 5-year-old. So, or I did have a sitter, but something happened and she wasn't able to get here. So that's why we're doing this over Zoom. Um, the topics we'll cover tonight in the PowerPoints we'll go over, we'll do PowerPoint, the second reproduction PowerPoint. So that's looking at the female reproductive system. And then I will go, and then we'll go over the development, pregnancy, and heredity PowerPoint insofar as much materials as what we will include on your exam. So I'll kind of cherry pick, and there are some slides toward the end of the female reproduction PowerPoint that we won't cover either. So I'll just make sure and make that really apparent to you all when we get to that material, so that you know to kind of not necessarily not pay attention to it, but you know that it won't be tested on for this 5th lecture exam. So, as I mentioned, this next PowerPoint, we're going to be looking at the female reproductive system, which shares a lot of similarities in many ways with the male reproductive system, but yet is different in some very crucial ways as well. Okay, so the first few slides here are going to hopefully be a bit of review, right, when it comes to gross anatomy. So for the female reproductive system, just like the male reproductive system, we have gonads and we have gametes. For females, the gonads are the ovaries, and the gonads are always the structures that make the gametes, right? So for females, the gonads are the ovaries, and the structures are what we call the oocytes or the ovum. I might have mentioned this already, but it's worth hearing again. Unlike males, females, the gametes for females, the oocytes, a female is born with all of the potential oocytes she'll ever ovulate in her lifetime. That's very different from the situation for males, where their gametes, the sperm, are made about every 2 weeks post-pubescently. And we'll get into kind of some more details on that as we go forward. By way of reminder, when it comes to the sex hormones, for females, we have estrogen and progesterone, where we have testosterone for males. And then just like the male reproductive system, we have accessory structures, and we have a duct system that allows the gamete to leave the gonads and then travel down to where that, in this case, that oocyte may or may not meet a sperm, right? And that duct system for females includes the fimbriae, which are the finger-like projections that you can see here at the top of the fallopian tubes. And then the tubes themselves, they lead into the uterus. And then this is the cervix, which includes both the opening itself and then this kind of neck region, if you will, that leads into the uterus, and the vagina, which is a tube, a muscular tube. Okay, so when it comes to gross anatomy and holding the uterus and the ovaries in place, the reality is I'm not going to test you on this information because I'm leaving it up to lab. But I left it on here because I think it's important for just the purposes of visualization to make note or to bring your attention to the fact that the uterus and the ovaries are held in place via ligaments, right? They're not just free floating in the abdominal pelvic cavity. I also want to point out, and I hope this picture illustrates it well, and I want to point out that the ovaries are not physically connected to the fallopian tubes. The ovaries are held in place by ligaments, by specifically the ovarian ligament. And then these finger-like projections, the fimbriae, kind of hover around or cup the ovary, so that when ovulation, which is an event that takes place once a month post-pubescently in females, when ovulation occurs and the mature secondary oocyte erupts from the ovary, it erupts essentially into a space, and then it is swept up by the finger-like projections of the fimbriae, and it's swept up into the fallopian tubes. And it's in the fallopian tubes that if sperm are present, this is where fertilization takes place. Fertilization does not happen in the uterus. It happens in the tubes. And that Might seem like a nuanced difference, but it's actually incredibly important because the time that it takes for the first that first cell that's going to become you, right, or me or anybody, that first cell that's called a zygote, which is the fusion of the two haploid gametes together, the time that it takes for that zygote to travel down the fallopian tube is really important for the development and the differentiation of that zygote into what we call a blastocyst. And it is only the blastocyst that is able to implant in the lining of the uterus. If you were to take a zygote and put a zygote in the lining of the uterus, it would not be able to implant. It has to be at a certain developmental stage in order to embed into the lining of the uterus and undergo further differentiation. Okay, so I'll just tell you guys, and hopefully this is now kind of familiar because you looked at follicles and talked about oocytes in lab. But one of the places I think people get hung up the most when it comes to getting confused with what's happening in the ovaries is keeping the follicle and the follicular stage separate from what's happening with the oocyte. So the follicle is the structure that holds the oocyte in the ovary, right? What you're seeing here are cross sections through the ovaries, and the oocyte is the actual egg, and the follicle is, again, the structure that holds the egg. And the follicle is made of these cells called, when there's just one layer of them and they're flattened, we call them follicular cells, right? The only time you see this situation where you see just one cell layer of the follicular cells around the oocyte is when the oocytes are found in what are called primordial follicles. Past that, you're going to find more than one layer of cells that makes up the follicle. And we call, when there's more than one layer of cells, we call those granulosa cells. Granulosa cells secrete estrogen. Well, they secrete estrogen and progesterones, but importantly, they secrete estrogen. And so the greater the number of granulosa cells that you have that make up the follicle, the greater the amount of estrogen that is produced. All right. Another thing I'll point out here as we're looking at this cross section through the ovary is that as the follicular stages mature and we go from a primordial to a primary to a secondary, and then finally, we're only going to focus on those 4 follicular stages: primordial, primary, secondary, and then the most mature stage is what we call the vesicular or the Graafian follicle. All of those follicles, except for the Graafian follicle, contain or hold what's called a primary oocyte. For what it is worth, actually, let me hold that thought until I get to the next slide. I'll get to this slide and say it. So for what it is worth, there is a difference between the way the maturation stage of a primary oocyte that's in a primordial follicle versus one that's in a secondary follicle. But that's going to be on the scope of this class. So for this class, I just want everybody to know that a primordial, a primary, and a secondary follicle all hold a primary oocyte. And what defines or makes a primary oocyte is the fact that this is a cell that is arrested in prophase 1. Okay, so what we'll do now, these are, this is a diagram or an illustration from your textbook, and I really like it because it breaks up the stages of life and kind of helps you think about what's happening with both the egg and also with the follicle, right? So as we started out saying, when a genetic female is born, that female has all of the eggs that individual will ever potentially ovulate. And all of those eggs are made during embryological development. And they are made, just like the spermatogonium, they are made from a germ cell. And we call this germ cell, in this context, the oogonium. And just like we see with the spermatogonium, those oogonium, again, this is happening during embryology, embryologically speaking for females. And so during embryological development, those oogonium are undergoing mitosis, right? And then what happens is, kind of later on, embryologically speaking, most, or let's say, the majority of those oogonium start to go into meiosis. and they get arrested right away. They get arrested in prophase 1, right? And that is how they stay dormant, right? And so then, of course, birth happens, and all through childhood, from birth until childhood, the ovaries contain primordial follicles that hold these primary oocytes arrested in prophase 1, and they're what we call quiescent, meaning they're quiet. They're not undergoing any kind of maturation. They're just sitting there essentially waiting for hormone signals, which we'll get to. Okay. The other thing I want to point out is, and because this is kind of an interesting phenomenon that's not totally well teased out, but when a genetic female individual is born, that individual has about 1.5 million primary oocytes and primordial follicles in their ovaries. And then what happens by the time that individual gets to puberty, that number has gone down to about 500,000. What happens, which follicles kind of disappear, if you will, that phenomenon is called atresia, is not understood. Clearly, it contributes to the genetic diversity that we see, but it ostensibly happens it ostensibly occurs kind of happenstance, right? So it's this paring down process that again ultimately contributes to the tremendous amount of diversity that we see genetically in our species. Okay, so I'll revisit this diagram here in a moment. So don't worry, I'm kind of skipping over this puberty to menopause portion at the moment. So because I'm going to talk about it in more detail when we get to Graafian follicles. So what happens is that after puberty, or once puberty occurs, which just like males, starts with this spike of GnRH from the hypothalamus. But what happens is that GnRH tells the anterior pituitary gland to secrete FSH and LH, again, just like what we see in male reproduction. And then these hormones, namely the FSH, follicle stimulating hormone, that's how it got its name, binds to the follicles in the ovaries and causes a handful of them. Again, we don't know why the handful that starts to mature, why that handful is that handful, but all the same, a handful, let's say 20 or so. Hold on, let me let this person in. A handful, about 20 or so follicles start to mature, and the maturation process involves more and more of these, or I should say thicker and thicker layers of these granulosa cells showing up, right? So it causes the follicle cells or the granulosa cells to undergo mitosis. These cells increase in number, and as they increase in number, they're able to secrete more estrogen, right? So as I mentioned, the more granulosa cells that you have, the higher the estrogen levels that are going to be secreted. So this primary follicle, again, there's going to be a handful of these that start to develop post-pubescently once a month. So we go from primordial to primary, still holding a primary oocyte in prophase 1. And then an even smaller handful of those primary follicles will continue to mature into secondary follicles. And some of the characteristics that are specific to secondary follicles is you start to see the development of what's called the antrum, which is this fluid-filled cavity. With secondary follicles, one of the ways you can differentiate between a secondary follicle and a Graafian or vesicular follicle is that with secondary follicles, you typically see the antrum that's not yet connected. So there might be, for example, 3 different compartments that are fluid-filled that have not yet merged into one. The other thing that is kind of specific to this stage, to the secondary follicular stage, is the fact that the primary oocyte is not yet completely pushed up against the periphery because the antrum is much smaller. But all the same, this follicle does still hold a secondary oocyte. You also, at the stage of the secondary follicles, see the development of what we call the corona radiata, which is this layer of cells right on the outside of what we call the zona pellucida. And the zona pellucida, you can think of it, it's this kind of like clear jelly-like layer that is right outside of the oocyte. And it's a layer that the sperm have to penetrate to gain access to the DNA that is to the oocyte itself, right? Kind of more on that to come. And then the most mature stage for a follicle is what we call the Graafian or the vesicular follicle. And the Graafian follicle has a very large antrum. The antrum is so big, in fact, that it pushes the oocyte to the periphery, which is really important because that makes it, when this follicle erupts, that makes it so that the oocyte can be ejected into that space between the fimbriae and the ovary itself. And then the Graafian follicle contains what we call a secondary oocyte. And this is an oocyte that is arrested in metaphase 2. And it is the secondary oocyte, so that cell arrested in metaphase 2, or I should say, let me say this a different way. The secondary oocyte is the only oocyte that, if sperm are around, is capable of being fertilized, right? So now I'm going to go back to this picture. So this is what's happening from puberty through ovulation, and it happens once a month after puberty is reached. And another thing I'll just point out at this stage is that for genetic females, once a month, what happens is, in general, this is not a hard and fast rule, but in general, every month, every other month, the same ovary ovulates an egg, right? So 1 month, it'll be the right ovary. The next month, it'll be the left. The next month, it'll be the right. Again, this is in general. There are occasions during which the left ovary maybe fires up 2 months in a row, or there are situations in which both ovaries fire off at the same time. And in that situation, you can end up with fraternal twins. You can also have a situation in which one ovary releases 2 secondary oocytes. But in general, it's usually one oocyte that matures and is ejected per month. Okay, and this is what the process looks like. So here we have, again, a primary oocyte in prophase 1 in a primary follicle. Because of the increase in granulosa cells, these follicles, because there's 20 or so of them, are secreting estrogen, and that estrogen continues to kind of help this process by which the follicles continue to mature. So a small handful of the primary follicles will then develop into secondary follicles. Again, still a primary oocyte, still in prophase 1. And then what happens again is that you have just a small handful, let's say 4 of these secondary oocytes that then develop or mature into the vesicular or Graafian follicular stage. And what happens during this process is you get this primary oocyte. It finishes meiosis 1, and it starts to go into meiosis 2. So when it finishes meiosis 1, right? Remember, if you can think back to meiosis, what you get at the end of meiosis 1 are 2, technically speaking, haploid cells, because they have 23 chromosomes, but these cells have 2N genetic information, meaning that these are haploid cells, because again, there's just 23 unique chromosomes, but these chromosomes are stuck to their sister chromatids. So these are not functional haploid gametes, right? Another thing that makes this situation different from male reproduction is that in finishing meiosis 1, only one of these 2N haploid cells is functional. The other one is what we call a polar body, and polar bodies are not really well understood. They're small, they're not functional cells. They have the 23 chromosomes, but aside from that, they don't contain any of the other structures that would make a cell a functional cell. So only, and again, this contributes to genetic diversity. So only one of these 2 haploids will become the haploid cell that can finish meiosis. And this haploid cell is arrested in metaphase 2. And this is the haploid cell that gets ovulated, right? So then what happens is that this secondary oocyte meets up with a sperm in the fallopian tubes, and that sperm, or a sperm, is able to penetrate the zona pellucida. The process of that cell penetrating the zona pellucida causes that gamete to finish meiosis, And in doing so, of course, it's going to result in the formation of two quote unquote gametes, right? Although one of them is another polar body that's non-functional. And then this one, this functional gamete becomes what we call the pronucleus. And the sperm, head of the sperm, that gamete is also called the pronucleus. So at that point, we have the pronucleus of the sperm, the pronucleus of the oocyte, and they can fuse to become a diploid cell. And we call that diploid cell the zygote. Okay. Sorry, you guys, I'm dehydrated, so drinking lots of water. Another thing to kind of take note when you're looking at this picture is that what happens too, so this is showing you the process of the vesicular follicle erupting and ejecting the secondary oocyte. So what that follicle does is it then deteriorates into something called the corpus luteum. And the corpus luteum is a temporary endocrine structure. What the corpus luteum does is it secretes progesterone, and progesterone does a lot of things, but one of the very important things it does from the perspective of reproduction is it maintains the lining of the endometrium, right? So it prevents a woman from menstruation starting, from shedding the lining of her uterus. And it does so, the corpus luteum does so to allow for that time, that about 7 days that it takes for, if a zygote is formed, for that zygote to travel down the fallopian tube, to mature into a blastocyst, and then drop into the uterus, right? If that happens, if we have a zygote that turns into a blastocyst that then gets into the uterus and implants, that blastocyst, and we'll talk about the structure that does this later on in this lecture, but that blastocyst has differentiates, and part of one of the structures that forms is something called the syncytiotrophoblast. I'll say that word again, so don't panic if you didn't get it right now. But that structure starts to secrete a hormone called HCG. HCG is the hormone that is tested for in pregnancy tests. And what HCG does is it talks to the corpus luteum and it tells the corpus, or it prevents the corpus luteum from degenerating further into the corpus albicans, which is what you're seeing here, which is scar tissue. And so HCG will help to maintain the corpus luteum all throughout the first trimester so that progesterone levels stay high enough to maintain the pregnancy up until the point where the placenta is large enough that it can take over the role of being the temporary endocrine structure. Okay, so that's what, and so I kind of talked my way through a lot of these sites here because I like that diagram. But the corpus luteum, again, just remember it's a endocrine structure. It secretes progesterone. And what progesterone does is it helps to build the lining of the endometrium and then maintain it in the event that fertilization has occurred and a blastocyst will be able to implant. And then, as I mentioned, the corpus albicans is basically just scar tissue. It's scar tissue that oftentimes is just absorbed, so you can't even see it in the ovary. Other times, if you were to do a post-mortem, for example, cross-section through an ovary and look at it, you can see some remnants of corpus albicans, but you can't count them like you could, for example, the rings of a tree to determine how many times ovulation has occurred. It's kind of random as far as how many of those little bits of scar tissue will remain. Okay, so we're now going to move in and start talking about what happens phase-wise, the kind of the events that occur in the ovaries, and we're going to compare that and contrast that to what's happening in the uterus and the hormones associated with it. One other thing I just want to point out, so ovulation is actually an event more than it is a phase. It's an event by which the Graafian follicle ruptures and ejects the oocyte into that space between the oocyte and the fimbriae. Okay, guys, so if anybody has any questions on that material, now's a great time to ask. Again, just kind of keep in mind oogenesis. Oogenesis in this context describes a process by which an oocyte matures from primary to secondary, and it occurs again once a month. But all of the primary oocytes and primordial follicles. All of those are formed before birth. And again, they're arrested in prophase 1. And then after puberty occurs, a handful of those follicles every month will develop, and of those, an even smaller handful will get to the point where the primary oocyte matures into a secondary oocyte. And then of that small handful, only one is usually ovulated per month. Okay, so these are just the slides that go over what I talked through. So, like I said, if you have any questions, you can jot them down. If you don't want to ask them right now, there will be time to ask them later. And this has more information than you need to know, but I just included it to kind of remind people of what's happening during each one of those phases of meiosis. Okay, so I'm not going to spend, because I wanted you to get into the development and pregnancy PowerPoint, I'm not going to spend a lot of time, nor am I going to test you on homeostatic imbalances. But I guess suffice it to say that during meiosis, so we'll talk in a moment about polyspermy, which is a condition by which, or a situation in which more than one sperm penetrates an oocyte. And polyspermy is not something that is compatible with life. As for our species, we only function by and large with 2 copies of each one of the 23 chromosomes. However, there are situations that can occur during meiosis that can lead to having, for example, 3 copies instead of 2 of specific chromosomes. And most of those situations are either not compatible with life, or can lead to situations in which the fetus has issues that oftentimes lead to a very, very shortened lifespan, maybe only, from minutes after birth to several years in general. With the exception of chromosome 21. So chromosome 21, if we have 3 copies of it, that condition is called trisomy 21. It's commonly called Down syndrome. And that is one of the few situations, trisomy 21 is one of the few situations in which having a 3rd chromosome is compatible with life. And there are characteristics associated. It is a syndrome. So there are characteristics, or there are implications, I should say, for having that third 3rd copy of the 21st chromosome. But all the same, it is a situation that is compatible with life, which makes it somewhat unique, having the trisomy with that chromosome being something that lends itself to survival. Okay, so this information, again, is all information that should be familiar to everybody, because it's the same starting out when it comes to the hormones and the process of going into puberty. It's the same for females as it is for males, right? It all begins with GnRH, which is gonadotropin releasing hormone from the hypothalamus. GnRH causes an increase in FSH and LH from the anterior pituitary glands, and LH and FSH cause the follicles to begin developing, which then just further increases the amount of estrogen and progesterone that is that's going to be present. Another thing I'll mention now, and I'll say it again toward the end of this lecture, but high levels of estrogen and progesterone, just like high levels of testosterone for males, suppress LH and FSH and GnRH for that matter from the brain. High levels of estrogen and progesterone suppress FSH and LH. And LH, luteinizing hormone, as we'll get to in a moment, it's this spike in LH that causes ovulation. So, and I'm bringing this up because this is one of the ways in which birth control works. There are hormonal birth control methods, like certain birth control pills, that keep estrogen and progesterone levels high enough that LH spike is prevented. And so ovulation does not take place. Okay, so we're first going to go over what happens in the ovaries, and then we'll move in and talk about what's happening in the uterus. So this is a picture from your textbook, and I really like it. And in fact, my favorite, I don't have until the end of this PowerPoint, but my favorite of these diagrams also includes what's happening in the uterus down here. And the reason I like these is because it shows kind of overlays and allows you to compare what's happening in the ovaries with the uterus. Again, I don't have that picture here right now, but it is in this PowerPoint. And then it shows you how the hormones that we've just been talking about, how those are related to the events happening in both the ovaries and in the uterus. So starting out talking about the ovaries, right? And I should say this is just some background information to understand this. So this cycle is based on what we call a quote unquote normal 28-day cycle. That is not to say that people who have a cycle that is slightly longer or slightly shorter are not normal. It's just to say that 28 days is kind of this whole understanding this process is based on a 28-day cycle, and 28 days, that's the most common from a cyclical standpoint for females. But all the same, even if you have shorter cycles, those, I will say cycle length, we're not going to talk a ton about it, but cycle length does play a really important, very important role when it comes to if you're trying to do kind of natural family planning, birth control methods by which you are tracking your cycle and avoiding sex during that period of time during which you might be fertile. Knowing the length of your cycle is key in doing that effectively. Like I said, that's kind of beyond the scope of this class. So back to this side. So day one, right? Day one in the uterus is the first day that a person starts to bleed, the first day of menstruation, right? In the ovaries, days 1 through 14 are what we call the follicular phase. And it's called the follicular phase because between days 1 and 14 in the ovaries, what we're seeing is a maturation of the follicles and therefore the oocytes within the follicles, right? From a hormonal standpoint, what we see starting on day 1, and so if you think about, so let me go back and talk about it as if the uterus were here. At day 27, this would still be part of the menstrual cycle, right? This would day 27 to day 28 this would be right before the menstrual cycle begins, days 27 and days 28. And at this stage, the FSH and LH levels are pretty low, as you can see. And then right before a person's period or the menstrual cycle starts, you start to see this increase in FSH. And what this increase does is it causes the follicles to start developing. And as the follicles begin to develop, estrogen levels start to increase, right? So that's why you're seeing this increase in estrogen as the follicles get larger and larger. And then what happens right toward the end of the follicular phase is you see this spike in estrogen. And we'll talk about the feedback between estrogen and LH and FSH in a moment here. But right now, I just want to point out that once it's this increase in estrogen to a certain level that causes LH to spike. And it's the spike in LH that induces ovulation. Again, if you do not have this spike, you don't ovulate. So this spike in LH is incredibly important, and it directly precedes the event of ovulation. And then what happens is after ovulation, ovulation causes the destruction of the vesicular follicle. And so after you get the destruction of this follicle and it starts to degenerate into the corpus luteum, you see this dramatic decrease in estrogen because those granulosa cells have been destroyed, right? And then what you start to see, and this is all, I should say, post-ovulation, ovulation, all the way up to the end of this cycle is what we call the luteal phase, the luteal being named for the corpus luteum. And then because the corpus luteum now has been formed, it secretes progesterone. And so here is that high progesterone level. And again, what the progesterone does is it builds the lining of the endometrium and it maintains it. And it maintains it all the way up through the very end of the cycle, which again, we're now looking at days 27, 28. And if no fertilization has occurred and no blastocyst is around to secrete HCG, the corpus luteum will deteriorate into the corpus albicans, progesterone levels will drop, and that causes the functional layer of the endometrium to be shed, which kind of brings us back to day 1. Okay. So that is that's as much detail as I expect you to know. I do want you to know what the zona pellucida is. We'll look at that more when we get to fertilization and the development PowerPoint. But otherwise, I think I've said everything I want to say on this slide. Mittelschmerz. So Mittelschmerz is a phenomenon that not all females experience, but some do. And it is a phenomenon by which a person basically experiences kind of a twinge of pain and typically some spotting that's associated with ovulation. Like I said, it's not, I don't know what the percentage is, but not fewer women experience Mittelschmerz. Fewer women experience it than do not. So it's not a super common phenomenon. And then I already mentioned that in a small percentage of situations during ovulation, more than one mature follicle or secondary follicle, more than one mature or secondary oocyte is ovulated, and that can result in fraternal twins. Okay, so that's what this slide goes over as well, is just all the events that occur when it comes to the corpus luteum, how that's the structure that maintains the lining of the uterus. And then if pregnancy does happen, the structure, the HCG from the embedded blastocyst, from specifically the syncytial trophoblast, that is what talks to the corpus luteum and tells the corpus luteum to kind of stick around, if you will, and to continue to secrete progesterone in order to keep the functional layer of the endometrium intact until the placenta is developed well enough to take over the role of being a endocrine structure. All right. Let's see what else I want to say. Oh, so going to this phenomenon by which we have these both negative and positive feedback, right? So if we look at what's happening as LH and FSH, so this would be during the follicular phase within the ovaries. So as estrogen levels rise, we see this phenomenon, right? By which in the beginning, so on this increase in estrogen levels on this positive slope, you can see if you correlate that to FSH and LH, you know, as these levels get higher, initially that actually causes negative feedback to the anterior pituitary gland, and you see this drop in FSH and LH. And then if estrogen levels are allowed to get to this, then you see this kind of switch in phenomenon. So here we see, let's say, negative feedback. You don't have to know the actual concentration of estrogen required to cause this phenomenon. Just suffice it to say that at a higher level of estrogen will negatively feedback and suppress FSH and LH. But what occurs if you don't, what happens in the female body, if we're not talking about birth control pills or any kind of hormone manipulation, this is just what happens. Estrogen levels we get this switch by which if estrogen levels continue to increase, we go from negative feedback to positive feedback. And it's this positive feedback that causes the spike in LH that induces ovulation. And like I said, there are many hormonal birth control methods that basically make it so that a female's estrogen levels stay at this level right here that is associated with negative feedback. So at this level, we see suppression of FSH and LH, and that of course would stop ovulation. And so if you don't let this estrogen peak occur, you won't get the spike in LH required for ovulation. Okay, So that's what this slide goes over, you guys, is everything I just said with regard to the effect of estrogen on LH and FSH. The LH, again, really importantly, it's the spike in LH that causes ovulation. And without that spike, you do not get eruption of the vesicular follicle. And then again, the corpus luteum will maintain progesterone levels up until about day 27, 28. And if no fertilization has happened, then those levels, the corpus luteum will deteriorate into the corpus albicans. And we see a drop in both, a dramatic drop in progesterone, and that's what causes the functional layer of the endometrium to shed, but also a drop in estrogen as well. And estrogen and progesterone, aside from right here, oftentimes they kind of can mirror one another, and also these hormones work together. You can't have, if progesterone levels are not, for example, sufficient, what that can cause is, even if fertilization and implantation have taken place, if you don't have sufficiently high levels of progesterone, you can't maintain the lining of your uterus. And so that's one of the reasons why for women who are struggling with fertility, if it is determined that that woman has low progesterone levels, after implantation, those progesterone levels have to be kept artificially high in order to maintain the pregnancy, at least up until the point where the placenta can take over. Okay. So that's the skinny when it comes to the physiology associated with what's happening in the ovaries and the hormones. I'm not going to test you on the lecture exam on gross anatomy, right? But you do need to know, just to kind of complete this picture, that in order for the sperm to get to where the secondary oocyte is going to be found, the sperm have to swim up through the vagina, which is, again, an acidic environment, which we've talked about. They have to then swim. The cervix itself has typically a relatively thick mucosal layer that prevents substances, sperm included, from entering. Plus, the cervix at other times, aside from ovulation, the cervix is the opening itself is almost non-existent because it's so tight. And then what happens during ovulation is you get slight dilation of the cervix, so the opening becomes a bit larger, like what you're seeing here. And the mucus around the cervix thins, and that helps to, or that promotes the ability of the sperm to be able to get through the cervix into the uterus, and then from the uterus to swim up the tubes, so that if a secondary oocyte is there, those at least one sperm is present to fertilize that oocyte. All right, and then when it comes to the uterus and the layers, what I want you to know is I will expect you to know that the uterus obviously has a relatively thick muscular layer. That muscular layer is called the myometrium, and that muscular layer is smooth muscle. So it's obviously not under voluntary control, but it's it's absolutely critical to allowing the uterus to do what it does, which is to not only incubate or accommodate a fertilized structure that can develop into an embryo and a fetus, but also when that fetus is mature, the muscle, that smooth muscle, allows for contractions of the uterus, and those contractions are going to be what pushes the fetus through the birth canal during the birthing process. So having that smooth muscle there is key to what the uterus does. And then the inner lining of the uterus is what we call the endometrium. The endometrium has two different layers or stratum, right? We have what's called the functional layer and the basal layer, or the functional stratus and the basal stratus. The stratum functionalis, that is a layer of the uterus that is shed every month under hormonal influence, right? So lots of receptors for progesterone, for estrogens and progesterone in the endometrium itself. The basal layer is there to form once the functional layer is shed, the first 5 to 7 days of a woman's cycle, it's the basal layer that's there to rebuild the functional layer every month. The basal layer is not under the influence specifically of, it's not hormonally controlled the way the functional layer is. The functional layer, like I said, has lots of receptors for progesterone. So when those levels are, when those levels drop, that's when the functional layer detaches and is shed. Okay, so now this is the image that I was referencing that shows you what's happening in the uterus and allows you to correlate that to what's happening in the ovaries. So in the uterus and the uterine phases, right? The first 5 to 7 days, but this is a 28-day cycle. So we're going to say the first 5 days are what we call the menstrual phase. So during this phase, this is when progesterone levels, as you can see here, are very, very low. During this phase, this is when the functional layer of the endometrium is being shed, right? This is also, this first handful of days, what's happening in the ovaries. This is when the follicles are starting to grow. So during menstruation, progesterone levels are very low, but estrogen levels start to climb, right? And then again, about halfway up this estrogen peak, if you will, we see this negative feedback on LH and FSH here. And then once estrogen levels reach this kind of critical level, if you will, that spike in estrogen causes a spike in FSH and LH, and it's the spike in LH that causes ovulation. And then here you can see ovulation has occurred. Now we have the corpus luteum. FSH and LH levels after ovulation drop dramatically, but progesterone levels climb, and that's because of the corpus luteum. And this is building and maintaining the lining of the uterus. And then if no fertilization has occurred, then that's when you get deterioration of the corpus luteum into the corpus albicans. That causes progesterone levels to drop, and that causes the shedding of the lining of the uterus. And so days 1 through 5 are what we call the menstrual phase. Days 6 up through ovulation are what we call the proliferative phase. And then right after ovulation on day 14, days 15 through 28 are what we call the secretory phase. And the secretory phase, from a uterine standpoint, what characterizes the secretory phase is that you have a robust or a relatively thick lining of the functional layer of the endometrium in preparation for a potential blastocyst to arrive and therefore implant. Okay. And then there are, of course, various homeostatic imbalances that are associated with the endometrium. One of those is endometriosis, which is a complicated kind of disease process that we don't have time to get into any detail really about. What I want you all to know is that it's associated with it's an inflammatory condition. So it's associated with inflammation of the endometrium that can cause, in extreme cases, kind of erosion of the tissue. And then that endometrial tissue can get outside of the uterus and can grow outside of the uterus and cause further inflammation. Inflammation, of course, always results in scar tissue formation. So endometriosis, when left untreated, can result in problems and things like can make it difficult to become pregnant. Let me check the chat because I can see there. Let's see. When I was reading, I don't understand what it means by arrested. Oh, okay. Izzy, are we talking about arrested, the meiosis, like arrested in prophase 1, arrested in metaphase 2? Women have periods and others don't. Okay. So arrested just means, another word for arrested would be halt. So let me go back. Hold on one moment. To this picture, right? Hold on, guys. This picture right here. So what it means to be arrested is that the oocyte just stops going through the process of meiosis. So for example, when the oocyte is arrested in prophase 1, what that looks like is that if you were to look at that oocyte, that primary oocyte has 2 copies. So it's, if you were to look into the oocyte, it would have 2 copies of each one of the 23 chromosomes, right? And so it's a diploid cell, and those cells would be attached. Those chromosomes rather would be homologous chromosomes would be attached to their sister chromatids, and they would be saddling up next to one another right in the process of crossing over. So it just means that they start going through that process and then they halt, they stop. Same thing with metaphase 2. The secondary oocyte, it's a haploid cell, so it has 23 unique chromosomes, but those chromosomes are stuck to their sister chromatids and they're lined up on the metaphase plate. When do they start again? Oh, they start again only if a sperm penetrates the egg. So so only when the sperm penetrates the egg will that egg, and I'm calling it an egg, but oocyte, will that oocyte finish meiosis. And when it finishes meiosis inside, and this picture is a bit misleading because this is all happening inside the zona, or within the zona pellucida, deep to the zona pellucida within the secondary oocyte. What happens when the sperm penetrates is it causes a chemical reaction by which that cell or that oocyte finishes meiosis 2, right? And in doing so, inside of the oocyte, it makes a polar body, which just gets reabsorbed. It's nothing. And it makes a normal haploid gamete that can be fertilized or that can fuse with the gamete, the haploid set of chromosomes from the sperm. Yeah, it's not super intuitive. Like I said, this picture makes it look like what's happening here is happening all within the secondary oocyte. Let me go to the other questions. Okay, so what does the Plan B pill do? So the Plan B pill basically makes the uterus an inhospitable environment. So the Plan B will cause you to shed the lining of the uterus, even if a blastocyst has, or not even a blastocyst, even if a zygote has been formed. If you take Plan B, you will shed, you'll shed your endometrium. So it would cause you, it would make it so that a pregnancy didn't continue to occur. And then why some women have periods and others don't, Amber, that is a really good question. And it's kind of a complex one that's not totally well understood. It can be everything from, there's a condition like polycystic ovarian syndrome, which is a syndrome, and it's relatively common. It causes basically cysts to form in the ovaries, and it disrupts follicular development. So it disrupts estrogen and progesterone levels. And again, it's this kind of critical mass, if you will, for estrogen levels that causes the LH spike. So those people with PCOS oftentimes don't ovulate, or their estrogen progesterone levels are not synced well enough to cause like a normal cycle and shedding to occur. You can also skip a period or have an irregular cycle based on things like body fat content, but on either extreme. So, if you have very, very low body fat, for example, basically, without getting into too much detail, adipose cells are kind of pro-progesterone. So having very, very low body fat disrupts your estrogen levels. And so that also causes cycles can cause cessation of the cycles altogether. And then there are, of course, some people just have irregular cycles. They just don't, for reasons that aren't totally well understood, they don't go through this cycle, because in order to have those estrogen and progesterone levels that support both ovulation and the building and shedding of the lining of the uterus, you have to have correct follicular growth, and that is under the influence of hormones from the brain. And so sometimes if FSH and LH levels are not adequate, or if GnRH levels are not adequate, that can also cause disruptions in the cycle. But those are great questions. Let's see, some people with IUD, don't have periods at all. Yeah. So, and then Izzy, so, and the IUD, so the IUD, which is an intrauterine device, right? You can kind of get, comes in two flavors, so to speak, or two forms. A copper one that does not have hormones, and then ones that do have hormones. So the ones that have hormones, my understanding is that, like Mirena, for example, I think what those hormones do is they keep the levels of estrogen and progesterone to such a degree that either ovulation is inhibited and or having a little device in the uterus. So the uterus is pretty sensitive to if there's inflammation at all in the uterus, that makes it not a great environment for the blastocyst to embed into. So having the physical device in there makes the uterus inhospitable. And then for the hormone IUDs, it can keep those levels, for example, those levels of progesterone just high enough that the lining, the endometrium isn't fully shed. So women can either spot or they can just miss periods altogether. The copper IUD works, and it's really effective because it causes more inflammation. It's more irritating to the lining of the uterus than the hormonally impregnated IUDs are. Plus, copper ions have this effect. They basically, for lack of a better way to describe it, they decapitate the sperm. So the ions, the copper ions disrupt the junction of where the head of the sperm meets the midpiece. And so they cause the head to separate from the midpiece. So if there's enough copper ions around, or any copper ions around, the sperm, as the sperm swim into the uterus, they kind of fall apart. And that makes them obviously not capable of penetration of an egg. Yeah, right. So, and you can have PCOS and still have your period, and you can have PCOS and still get pregnant. Syndromes are tricky because syndrome is kind of a blanket term that is used to describe a conglomeration of physiological phenomenon that are associated, well, not always, we don't even know how, but in this case are associated with a particular condition, but it's a syndrome. And so people very much vary in their response. For some women, PCOS causes infertility and, causes kind of a host of issues. For other women, it might not cause infertility, but they might suffer from other kind of side effects, if you will, of having that condition. Okay, so let me get back to where, hold on guys. Well, I guess I don't think of myself as totally not tech savvy, but sometimes I just can't figure this out. Oh, whoops. Okay. So yeah, and I'm not going to test you on endometriosis, but it is a homeostatic imbalance that can impact fertility. It's also one of those kind of tricky conditions in that for some women, it's because it's inflammatory. For some women who have autoimmune disease, it might be kind of autoimmune in nature. For some people, they don't really know. And for some people, getting pregnant kind of cures their endometriosis. Getting pregnant and then the birthing process kind of resets the system, like clears out all of that tissue, problematic tissue. And for some women who had endometriosis after being pregnant, that endometriosis is completely resolved. Let's see, do levels of cramping follow along with what you have said about why some women have periods and others don't? It's another great question, Amber. And the answer is not entirely, but sometimes. So cramping is due primarily to contractions of the uterus, right? And so if you have inflammation, so for women who have endometriosis, yes, they have terrible cramping because they have inflammation in their uterus, and that causes the inflammation, or that causes the uterus to be irritable. But there are other women who have terrible cramping, but they have normal periods, and no, that we can tell anyway, no condition that can be specifically attributed just to the cramping. So, and then for some women, they don't get cramping at all. And also for women you might have really bad cramping one cycle, but not the next. So it's one of those things that's frustrating because it's not totally understood. Okay, guys, so this is just, like I said, I like these diagrams in case you can't tell, that overlay what's happening. I like this one in particular because it shows you what's happening in the ovaries, what's happening in the uterus, the hormones associated with those events, and the hormones coming from the brain, which start this whole process to begin with, right? GnRH and then FSH and LH from the anterior pituitary gland. All right, you guys, I think I said everything I want to say here. Again, just remember the uterine tubes, the fallopian tubes is what I default to calling them because that's kind of the historical name for the tubes. I think there's this movement to kind of leave using trivial names, if you will, to describe a structure. So uterine tubes is becoming a more and more common tube. And I apologize. I just, my default is to go down back to fallopian tubes, but those are the same thing. And again, ovaries are not actually connected to, not directly connected to the uterine tubes. There's a space between the fimbriae and the ovaries, and it's the fimbriae that sweep up the egg and into the uterine tube so that the secondary oocyte can be fertilized if sperm is present. Oh, well, I kind of had forgotten this side was here. Okay. So this, when it comes to contraception, right, this is a slide I have here to kind of address some of the different contraceptive methods that exist. And so contraception, there are several different ways to prevent pregnancy, right? Those ways some of them include hormones, some of them don't. When they don't include hormones, or I should say the methods that don't include hormones would include barrier methods. So barrier methods would be things like condoms and diaphragms and, the spermicide gels, things that essentially the barrier, meaning that sperm is prevented from ever coming into contact with a secondary oocyte. Lactation is another. So I have lactation on here because I think from an educational standpoint, it's important, especially for women who maybe don't want to be pregnant or to have multiple pregnancies and don't have access to birth control. Lactation can theoretically be used as a type of birth control. It is not a very reliable type because in order for lactation to work to prevent pregnancy, or I should say the way in which lactation works is that prolactin, which is a hormone that causes the mammary glands to make milk, high prolactin levels suppress FSH and LH. And so, and again, if you don't have that FSH and LH, specifically if you don't have that LH spike, you don't ovulate. So if you can keep your prolactin levels really high, theoretically, you should be able to prevent ovulation. And from an evolutionary standpoint, this makes sense because it's very energy expensive for a woman to lactate. And so it's not, again, from an evolutionary standpoint, ideal to have to put forth energy into both nursing a child whilst then also maintaining a pregnancy. However, again, for lactation to be reliable, a woman has to be breastfeeding very regularly and exclusively, because otherwise prolactin levels won't be high enough to suppress LH. And even in that case, sometimes for some women, you'll still get that spike in LH. So like I said, I think it's an important educational tool to teach women who maybe don't have access to birth control, but it's not nearly as reliable as the hormone or the barrier methods. Same thing with the rhythm method or the pull-out method. You have to be kind of on top of your game for those to be, and even if you are on top of your game, they're not reliable because there's always anomalies, right? Even if you track your cycle and you can, with relative certainty, predict when you're ovulating, there will be situations and months in which you have kind of an anomalous ovulatory cycle, and you might ovulate when you don't expect to. And then other types of devices include, as we discussed, the IUD, which is the intrauterine device, and then oral contraceptives or patches or the ring. All of those fall under hormonal birth control methods. And those work primarily by preventing ovulation, by inhibiting the LH spike, and you can inhibit it by playing with estrogen and progesterone levels. And then also by making the uterus an inhospitable environment and making it difficult for the sperm to get into the fallopian tubes by doing things like causing the mucosal layer around the cervix to be thicker than you would normally find. So, and as far as efficacy is concerned, the IUDs, I think, are aside from sterilization by cauterizing or cutting or tying the tubes, the IUDs are the most efficient or effective birth control methods, followed by the oral contraception or patches or rings. And the reason oral contraceptives specifically have a lower than what you might expect efficacy rate is usually because in order for them to work, they have to be taken consistently, and they should be taken at the same time every day, right? Because it's all about manipulating your cycle. And so if you don't, for some women who are really sensitive, even if you're taking a pill every day, if you take one day, you take it in the morning, the next day, take it in the evening, just that little variation can make you susceptible to ovulating. And then the morning after pill, again, makes the uterus an inhospitable environment. It can help to inhibit ovulation, but even if ovulation has occurred, it can help, even if ovulation has taken place, it prevents implantation. Okay, and then permanent methods of sterilization include, for females, tubal ligation, which is disruption. I guess for both males and females, the quote unquote permanent part has to do with the fact that the duct system is disrupted. So for men, this involves severing the vas deferens or the ductus deferens to prevent the cellular sperm from getting mixed in with the seminal fluid. And then for females, it involves disruption or making it so the secondary oocyte can't leave the fallopian tubes and get into the uterus. And that can occur by either tying or banding or, kind of cutting and cauterizing, which is to burn the two ends of the tube. And this is the most effective way of preventing pregnancy. For women, tubal ligation is a much more invasive procedure that involves, it's a surgical procedure. For men, I used to joke and say it's kind of like going in and having your teeth cleaned, and that's me being flippant. It's not entirely accurate, but it's a in-office procedure that is much less invasive than tubal ligation, female tubal ligation. Okay, and then homeostatic imbalances related to pregnancy. So I just want you to be familiar with the term ectopic pregnancy. Ectopic pregnancy is the word used to describe a pregnancy that occurs outside of the uterus. And I guess the take home with this is that if a pregnancy occurs outside of the uterus, if the blastocyst embeds anywhere other than the uterus, that is not something that is compatible with, it's not compatible with life for what could become the potential fetus. And it's also dangerous for the female. So the blastocyst itself is really good at just finding vascular sources. So the blastocyst can feasibly implant into the lining of the fallopian tube and start to grow there. And that's because the blastocyst, once it embeds, it's basically chemically communicating with the cardiovascular system, with the vasculature, to find vasculature that it can attach to and then cause angiogenesis, which is the generation of additional blood supply. So if let's say somebody has a disruption in the fallopian tubes, and that blastocyst can leave the fallopian tube and get into the abdominal pelvic cavity, it could feasibly implant into the abdominal pelvic cavity and begin to grow. Of course, that's not an area that is designed to handle the growth of and maturation of an embryo to a fetus. So that is not something compatible with life, nor is it compatible with life to have the blastocyst implant into the fallopian tubes. And so in these situations, the blastocyst and the developing structure has to be removed, because what will happen, if, especially if it's in the fallopian tube, like what you're seeing here, is at a certain point in growth, the uterine tube will explode because it's not meant to accommodate a developing structure. Okay, and then when it comes to cancers, what I want you to know, so just like when we were talking about male reproduction, there are cancers associated with the female reproductive tract. Those would include ovarian, cervical, and breast cancers. Of those, ovarian tends to be kind of particularly insidious just because we don't have any good tests for ovarian cancer. So by the time ovarian cancer is caught, that cancer is oftentimes progressed to the stage of being metastatic. There are certain genetic conditions, like having the BRCA mutations, BRCA1, BRCA2 mutations, that make an individual more susceptible to developing ovarian and breast cancer. And up to, I have here, if you have a BRCA mutation, that can, about half of the time, those individuals will develop ovarian or breast cancer. And by the time they're, I think, on average in their mid 30s, but all the same, and so that's good information. Let me finish on this thought. That's good information to have. I think anytime you have additional info, it allows you to make more informed choices. And a lot of women will choose, if they know they have a BRCA mutation, if they know they want to have children, to freeze their eggs, and to have the ovaries removed, and a hysterectomy and breast tissue removed, just to avoid this likelihood that they will develop, because there's such a high likelihood they'll develop cancer of the reproductive structures. But like I said, ovarian cancer, unfortunately, there's no great test to prevent it. And that makes it different than breast cancer and cervical cancer, because we have screening methods that are much more effective for those types of cancers. For breast tissue, what I really want you to know, so the areola is I guess, to begin with, both males and females have mammary tissue. Both males and females have areolas, and they both have nipples. And then the difference between the reason women tend to have larger breasts and are able to lactate after giving birth has to do with the hormone profiles. So estrogen is very pro mammary gland development. So under the influence of estrogen, mammary tissue develops, and that is why, as a female goes through puberty, she develops breasts. And then in order to lactate, you need two hormones, and those two hormones are prolactin and oxytocin. Prolactin, the acronym is PRL. Prolactin is the hormone that causes the mammary tissue to make milk, and then oxytocin causes ejection of the milk from the nipple. I bring up the thing with males and females because there are situations, for example, with certain types of pituitary tumors, conditions by which men can grow breast tissue and can even kind of lactate, which is obviously not a normal, that would be indicative that there's some kind of hormonal disruption or some kind of erroneous hormonal event that is occurring for that male. And then for breast cancer, again, we don't have a lot of time to go into talking about this homeostatic imbalance, but I just want you all to take away that about 70 to 75% of breast cancers have no known risk factors. So that's pretty high. There are risk factors that make a person more susceptible. The BRCA mutations, which we already talked about, things like having basically hormone exposure over time. So if an individual has an early onset of menses, let's say age of 10, and they don't go through menopause until the age of 60, their tissues are going to be exposed to estrogen and progesterone for longer periods of time than somebody who didn't start their period until they were 16 and went through menopause when they were 50. So there's a correlation with estrogen and progesterone exposure and a risk for developing breast cancer. Pregnancies late in life, no pregnancies at all. There's a correlation there. There's risk factors, right? But again, over 70% have no risk factors. And so it's why screening becomes so incredibly important. And then the treatment for breast cancer, of course, will depend on the stage and the specific characteristics of the particular tumor that's developing, whether or not there's certain, it can be estrogen, progesterone positive, HER2 new. There's all kinds of different markers that you can use, that I should say oncologists can use to kind of customize a treatment for that particular person and their particular tumor and the characteristics of their tumor. Okay, and then just like with males, females, of course, have secondary sexual characteristics. And just like with males, those secondary sexual characteristics develop under the influence of the sex hormones. And for females, those are estrogen and progesterone. So estrogen in particular causes, we just talked about mammary tissue growth. It causes maturation and enlargement of not just the breast, but also the vagina, the uterus. You get, thickening of the mucosa that's associated that you find both in the vagina and the cervix. Just kind of preparation. The estrogen is primarily responsible for the preparation of the female's body to be able to both ovulate and then, if pregnancy occurs, to sustain a pregnancy. So that's what these slides go over. And then menopause. So for females, menopause is an event that occurs anywhere, from over the course, typically takes, I think, from start to finish, if you're talking about perimenopause all the way through menopause being complete, takes about 10 years. But what characterizes menopause is that you get cessation of ovulation. So you get cessation of development of the follicles and the oocytes within the follicles. Because you don't get the development of the follicles, you don't get an increase in estrogen and progesterone. And so progesterone and estrogen levels post-menopausal stop altogether, and not stop altogether, sorry, are very, very low compared to what those levels are in women during the years, their I guess, fertile years. And along with this, you get, because you don't get this change in estrogen and progesterone, because you don't get follicular development, you don't get a period, or you don't menstruate anymore. And so menopause, I think in order to technically be in menopause, you have to be of a certain age and you have to have not had a period for over 6 months. And at that point, you can kind of reliably assume that you're no longer fertile. And if you've been trying to prevent pregnancy, you no longer have to really worry about things like birth control and things of that nature. There's no exact equivalent of that for males. They do have the male climacteric event, which we discussed, which is just in males, you see this steady decrease in testosterone that makes them less fertile, makes the sperm that they produce less viable, kind of poor quality, if you will. But there's no event in which there's nothing that a male goes through that in which they just stop making sperm altogether, which is kind of what you see obviously with females. Okay. And then for STDs, what I want you guys to know, so STDs, as far as the infectious agent that causes them, they kind of run the whole spectrum of, we have STDs that are viral in nature, bacterial, fungal. Bacterial STDs, historically speaking, since the advent of antibiotics, have been easier to treat than viral infections. With the kind of advent, if you will, of antibiotic resistant strains of bacteria, this is kind of changing. But some of the more common STDs that exist, so we have gonorrhea, it's bacterial in nature. A lot of the bacterial STDs, one of the big risk factors associated with them is the development of what's called pelvic inflammatory disease, which causes scarring, and if left untreated, can render somebody infertile. And like I said, anything that's antibiotic or that's bacterial in nature is treated with antibiotics. So those diseases would include gonorrhea, syphilis. Syphilis is kind of unique for the bacterial infections, and that if left untreated, it can get into the central nervous system and cause irreparable damage. So ultimately will lead to death. But again, it is treatable with an antibiotic if caught early enough. Chlamydia is the most common of the STDs. It's kind of particularly insidious because it is so infectious, and it also can be, for the STDs, kind of, relatively speaking, asymptomatic, especially in men. It's again, PID, which is pelvic inflammatory disease, is the main risk associated with it. And then for viral STDs, we have HPV, which has many, many different strains. HPV is a virus that infects epithelial tissue. So it is not a bloodborne virus. It is a virus that is found in the epithelial tissue of the genitals. So in the vagina, also males carry that virus if they're infected in the epithelial tissue in the pubic region. And HPV can cause, from a lesion standpoint, it can cause what's called genital warts. And then in female, I guess in both males and females, HPV is many viruses, in fact, are mutagenic, right? And that's because the way in which a virus works is it inserts itself in some shape. Well, it either inserts itself into your DNA and or it hijacks the machinery, it hijacks your ribosomes. But especially with DNA viruses or with retroviruses, so viruses that are mRNA and then get converted into DNA within the cell and then inserted into the chromosome. Anytime you insert something into a chromosome, you are causing a mutation. And so that puts you at risk for developing cancers. So the difference, why HPV is so kind of much more why it causes cancers in females and you don't hear about it causing cancers in males, is because for females, that epithelial tissue is found, much of it is internal, right? The vagina is a muscular tube that is lined with epithelial tissue all the way up to the cervix, which is also lined with epithelial tissue. And so if that tissue becomes infected, it's harder to kind of exfoliate or to slough off that tissue. It's an easier environment for the virus to spread from cell to cell and to cause cells to undergo mutation. And then some of those mutated cells can become cancerous. In males, the only time you really see male-associated HPV cancers is in, I guess, like homeless populations of males who are not able to access and don't maybe take showers as often. And so they're not sloughing off those cells to the same degree. But in either case, HPV is no matter who is infected, HPV is it is a mutagenic type virus. Another thing about HPV that makes it somewhat unique is that it is incredibly prevalent. So I mean, these stats come from maybe 5 years ago, but it's something like 85% of individuals who are sexually active who have had more than one partner have HPV. And males tend to be kind of silent carriers. Females, you can do a pap smear, a swab of the cervix and test those epithelial cells. For males, it's much harder. So the default assumption is that any sexually active male is a carrier. And of course, there is a vaccine for the most common strains of HPV that cause cancer, because not all the strains of HPV cause cancer. It's just a handful of them that do. So that's what this slide goes over, right? And the HPV vaccine has been really effective. It's reduced, again, I don't have the stats on me and I need to get them and put them in my PowerPoint, but it has reduced cervical cancer prevalence to a statistically significant degree. And it's a vaccine that is really well tolerated. Okay, guys, so here's another slide. I love these diagrams that show hormones and what the hormones do to the gonads, male and female, and then what happens in response to those hormones with development of the gametes. Oh, okay. So you guys, let's take a 10-minute break, and we will come back, like a 10-minute bathroom break. We'll come back at, call it 7:36 to 7:40, and we will do the last PowerPoint, which is development, heredity, and pregnancy. And we're not going to actually, I'm going to kind of cherry pick information from that PowerPoint that I want you to know. That'll be it. So I'm going to stop the share and I'll pause the recording, and then we will pick back up in 10 minutes.
I have a question.
Sure.
Would you mind posting this recording on Canvas?
No, not at all. I'll post the
Perfect.
last one. Do you guys not? So this, out of curiosity, when I post these links, when you click on the link, does it not then allow you to get into the cloud associated with this? Have you tried that? I'm just curious. I'll still post it, but
I think it usually works. Yeah.
it does. Okay, yes, I absolutely will post it, but yeah, I wasn't 100% sure whether or not you should be able to, all of these should be stored in a cloud that all of you have access to, but I'll post it just on our in our announcements, and I'll post this week's and last week's.
Yeah, that would be great. Thank you.
Yeah, yep, no problem. Okay, guys, I'll see you in 10 minutes. All right, so I'm back. So we will just jump right into the last PowerPoint. Which goes over, this is material from chapter 29. And this is the material that covers the events that occur, basically kind of starting with fertilization through pregnancy. So after fertilization, there is a series of changes that occur. And those changes include things like differentiation, I guess, growth of this mitosis, and so an increase in cell number, an increase in differentiation and specialization of the cells. And ultimately, that will lead to the development of an embryo. And then from an embryo, if things continue, to a pregnancy. So that, again, is kind of what we're going to cover right now. So this is a diagram from your book, and I like it because I think it does a good job at allowing you to visualize what occurs during the different periods, right? We broadly break the events starting from fertilization up through giving birth. We call them different phases or periods, right? So the pre-embryonic period starts with the formation of the zygote, and the zygote is the first single-celled structure that will become you as an organism, as an individual. Characteristics of the zygote. So the zygote is the cell that forms when you get the fusion of the pronuclei from the secondary oocyte that then again finished metaphase 2, became a haploid gamete, and when it fuses with the pronucleus from the sperm, another haploid set of chromosomes, another gamete, that forms the zygote. So a zygote is a diploid cell. It's 2n46. And from the formation of the zygote all the way through the development of the up through, I guess, implantation, we call that the pre-embryonic period. Then we have something called gastrulation, which is takes place kind of during just 1 week. And gastrulation describes, or what characterizes gastrulation is you get the differentiation and therefore the development of the primitive tissues that are going to become all the tissues of your body. And then after gastrulation, still a part of the prenatal period, we have what's called the embryonic period and then the fetal period. And the embryonic period describes all of the events that occur that make that structure what we now call an embryo. And then the fetal period is characterized by growth and development of the structure of what was the embryo into the fetus. And there are some very specific events that allow you to tell which phase you're in when it comes to development. The prenatal period is just a blanket term to describe all of the changes that occur starting from fertilization through delivery of the fetus. And so we're going to talk about the events that occur in each one of these, right? So fertilization, we've talked about. It's kind of where we stopped with the second PowerPoint, was the meeting of the fusion of the pronucleus and the formation of the zygote. And then what happens is, and again, this occurs in the ampulla typically, but definitely in the fallopian tubes, in the first portion of the fallopian tubes. So what happens after zygote formation is that this cell starts to undergo rapid mitosis. And it specifically undergoes a type of mitosis that's called cleavage. And what makes cleavage unique is that with cleavage, you see an increase in the number of cells without a corresponding increase in the size of the structure. And that's really important because you don't want, because again, this structure is traveling through the uterine or the fallopian tubes, which are of a very specific and relatively small size. So if you didn't have cleavage, if you were getting mitosis and you were getting corresponding increases in size in the structure in the uterine tubes, what would happen is that structure would likely get too big to allow it to pass through the uterine tubes. So having cleavage take place allows for differentiation and specialization and an increase in the number of cells without compromising the ability of that structure to make its way into the uterus. So we go from, again, zygote to the next stage, and we have a 4 and an 8 cell stage that we're not going to focus a ton on. But the next kind of stage that we discuss as a differentiated stage is the development of what we call the morula. The morula is still a solid ball of cells. It is the same size as the zygote, but, let me back up a minute. It is roughly the same size as the zygote, but it is slightly bigger. And there's some differentiation or specialization of the cells that takes place. So from the morula, when we get to the morula stage, this structure is now getting close to leaving the fallopian tubes. And after the morula stage, we get the blastocyst stage. And the blastocyst stage is characterized by a couple of things. You get an increase in size, and you get, obviously, this is no longer a solid ball of cells, right? You get the development of this cavity that is filled with fluid. The outer ring of cells is what we call the trophoblast. And then we have this inner group of cells that is called the inner cell mass. And within the inner cell mass, we have what's called the embryoblast. So these are the cells that are going to become the embryo. And then if things continue, the fetus, and then the trophoblast cells become everything from the chorion, which is going to be it's going to include umbilical, basically the vasculature that connects fetal and maternal, or allows for the communication of fetal and maternal circulatory systems. And this is the structure that it has to be, I should say, this structure needs to be at the blastocyst stage in order to be capable of implantation into the lining of the uterus. When implantation takes place, oh, and one other thing I want to point out is that from fertilization to the development of the blastocyst stage, that process takes about a week. So it takes about a week for the zygote to make its way all throughout the uterine tubes, or fallopian tubes, and to drop into the cavity of the uterus. And then once it gets into the cavity of the uterus, it takes about 3 days, more or less, for 3 days to maybe 5 days for it to implant into the lining of the uterus. Once the blastocyst implants, what happens is we see the development or differentiation of the trophoblast into cells that are called the cytotrophoblast, and then something called the syncytiotrophoblast, which is what you're seeing here. And the syncytiotrophoblast is the structure that secretes ACG, which again is the hormone that communicates with the corpus luteum and tells it to stick around and to continue to produce progesterone in order to maintain the lining of the uterus. Right? So fertilization, just some events that occur during fertilization that I want to draw your attention to. So during fertilization, what happens is you have at this point a handful of sperm, let's just say 50. We begin for, let's say, 2 mils of ejaculate that are deposited into the vagina. That would have over 200 million sperm in it, right? So from that initial group of 200 plus million sperm, we end up with, and these numbers are not hard and fast numbers, but just for kind of to give it some context, we go from over 200 million to about 50 that actually make their way to that secondary oocyte, which is in the ampulla of the uterine tubes. When those sperm get there, they kind of snake their way through the corona radiata, and they encounter the zona pellucida, which again is that layer outside of the secondary oocyte, which is kind of gel-like in consistency. And that layer, the zona pellucida, has a lot of receptors for the sperm that are that the sperm can then dock onto the zona pellucida. And they start to they bind to those receptors, and there is a reaction that takes place by which the acrosome cap falls apart. Those digestive enzymes chew through the zona pellucida, and the first sperm that is able to get through the zona pellucida and kind of merge, there's this, for lack of a better way to describe it, that there's a chemical reaction that takes place when a sperm gets through the zona pellucida that causes the secondary oocyte to pull that, what is now a pronucleus, because the tail gets stuck and left in the zona pellucida, pulls that pronucleus into the secondary oocyte. When that happens, and I shouldn't say the first sperm, it's just one of that group that made it to the oocyte. One of those sperm, the first one that's able to get through the zona pellucida and merge and fuse with the membrane of the secondary oocyte and pulled into where the chromosomes for the secondary oocyte reside. That event causes crystallization of the zona pellucida so that no other sperm, even sperm that have bound to the receptors and are trying to kind of make their way into the secondary oocyte, that crystallization prevents any other sperm or the chromosomes associated with those sperm from gaining access to the inside of the secondary oocyte, which is where that set of DNA resides that's again arrested or halted in metaphase 2. And it's that process of the fusion that causes metaphase to be completed so that you get the polar body and then the formation of the pronucleus for the oocyte that merges with the pronucleus of the sperm. And that's really important because it prevents polyspermy. Like I said, there's no situation by which which 2 or more sperm penetrate and merge with the secondary oocyte that is compatible with the development of that structure into an embryo, into a fetus. So if polyspermy does occur, then that secondary oocyte does not become a zygote, and it is just an unviable structure that doesn't do it. I mean, in that situation, a person would go through their menstrual cycle and probably never even be aware that, unless it was being somehow monitored by researchers, would never really even be aware that for anything resembling fertilization had occurred. Another important thing that I want to point out, again, we're not going to in this class talk about, kind of if you're tracking your cycle days in which that window kind of fertilization, but I just do want to draw your attention to the fact, so once sperm get into or deposited in the vagina, you can have sperm that live up to 5 days in the female reproductive tract. The oocyte, once ovulated, is viable for more or less 24 hours. So there's actually this week window, more or less, depending on the length of the cycle of the female, a week during which an individual, if that female is fertile and comes into contact with sperm, during which fertilization can occur. Because if sperm are present in the reproductive tract when ovulation takes place, then that oocyte, of course, can be fertilized. So it's why they say when you're trying to do kind of natural family planning by tracking your cycles, you have this window on either end. You basically have the 5 days leading up to ovulation, the day of ovulation, and then the day after, during which you should not come into contact with viable sperm if you're not interested in becoming pregnant. And I just point that out in case for people, like I said, it's beyond the scope of this class, but there are ways you can kind of track your cycle and calculate those numbers and to give you a better idea of what your specific situation is. Okay, so what I want to point out from this slide, again, here you can see development of the zygote to the blastocyst. Again, this is the stage that the structure needs to be at, developmentally speaking, in order to be capable of implanting into the lining of the uterus. And then when it comes to the trophoblast versus the embryoblast, what I want to point out, so that the blastocyst itself, again, it has a group of cells. This group of cells is often just kind of layman's term called the inner cell mass, and that includes the embryoblast. So these are the cells that are going to become the embryo, and then if the pregnancy continues, the fetus. And then these cells here are the trophoblast cells, and one of the first differentiation events that occur is the trophoblast into the cytotrophoblast and the syncytiotrophoblast. And the syncytiotrophoblast is the structure that secretes HCG. Another thing I'll point out is that this group of cells, this embryoblast cells, these cells are what we call pluripotent. So all of these cells are stem cells, right? From, technically from this 2-cell stage through the development of the embryoblast. These are stem cells that, if harvested, can be given certain chemical signals that cause them to differentiate into any tissue in the human body. So it's, when kind of the controversial stem cell issue has to do with the fact that the cells are best harvested somewhere in these stages to be used for stem cells. These cells from a stem cell standpoint are the most pluripotent of cells. You can get stem cells from other sources, but these are the ones that really kind of, I guess, bridge that, fall somewhere within either being pluripotent or almost omnipotent, meaning they can become anything, depending on the chemical signals that they're given, even tissues from other species if given those signals, which is kind of crazy and way beyond the scope of this class, but just to point that out. Okay, so so that's kind of what I want you guys to take away. I want you to know what the syncytiotrophoblast is, just because it plays such an important role in secreting the hormone that's responsible for maintaining the corpus luteum, which is the structure that maintains the lining of the uterus, all the way up through the end of the first trimester until the placenta is developed enough to take over that role. And another kind of take home from this is it takes about, right, so day 9, but it takes up to 2 weeks from the time ovulation takes place for that blastocyst to be fully embedded into the lining of the uterus. And once the blastocyst is, so kind of at the end of week 2, once that blastocyst is fully embedded and has undergone enough differentiation, we start to call it at, week 3, really, an embryo. And actually, I'm going to skip over this slide aside from the fact I just want to point out the chorion. The chorion is the cells that become the chorion are the cells that ultimately become the placenta. And the placenta is a really important structure. I think people oftentimes have a hard time visualizing or picturing what the placenta looks like, but it's basically what it's made up of. It's like an entanglement of blood vessels, and it kind of looks like this gelatinous glob that's roughly the size of, I don't know, maybe like a really big pickleball. And it's adhered to the uterus. And it's that entanglement of vessels includes vessels from both the maternal side and then also fetal vessels, and the fetus itself, well, the embryo into fetus is attached to the placenta through what we call the umbilical cord, which is a structure made up of the fetal vessels, right? And what the placenta does, which is on this side, is it allows for communication between the maternal system and the fetal system. So the placenta is how the developing embryo and fetus gets access to oxygen. It's how the CO2 that is made by this developing structure is disposed of by causing fetal CO2 levels. Well, I guess I'm getting a bit ahead of myself, but during pregnancy, especially into the second trimester, the respiratory rate, the maternal respiratory rate increases dramatically. And one of the consequences of this is that if you breathe faster, you're going to blow off more CO2. And so maternal blood tends to be relatively, compared to a non-pregnant, that same person who's not pregnant, tends to be lower in CO2 and high in oxygen, right? Fetal circulation, or embryo, I'm going to call it fetal circulation because that's really when the circulatory system is established, is in the fetal period. So fetal circulation tends to be high in CO2. And so having this gradient by which maternal blood has lower than normal levels of CO2, and fetal CO2 is much higher than what we see in the maternal system, allows for the CO2 to rapidly diffuse from the fetus into the maternal blood supply, so that the pregnant woman, when she breathes out, is breathing out not only CO2 she is making, but also the CO2 that's being produced by the developing structure. And the O2 levels being high in maternal blood allow for the oxygen that's found in the maternal blood to very quickly establish as a gradient that is steep, that promotes the diffusion of oxygen rapidly from maternal circulation into fetal circulation. This is also, the placenta also allows for, or this is how the fetus gets access to nutrients by way specifically of things like glucose. So, and we'll talk about other adaptations that we see in pregnancy that help to promote the ability of the fetus to gain access to glucose, because there's so much differentiation and there's so much glucose that's required in order to maintain, promote development of that structure, of the developing structure, the developing embryo to fetus. You also find with the placenta that communication between maternal and fetal systems, allowing for antibodies, specific antibodies, in particular IgG, right? And also to some degree IgM, to leave the maternal system and get into fetal circulatory, the fetal circulatory system, in order to provide protection to that developing structure, protection to anything that the maternal system might be and have encountered, right? So this is why if you, I guess to tie in, I don't know, we're going to tie in vaccination just because it's so relevant right now to, and just in this particular context, to the developing fetus. It's why reason, it's part of the reason why vaccination is so promoted in pregnant women, is if you vaccinate the pregnant woman, that woman will make antibodies, and those antibodies will be then transferred to the developing embryo and fetus, and hopefully protect that embryo and fetus from any potential infection that, or I should say that the infectious agent that pregnant woman was vaccinated against. Let's see, I have something in the chat. For a blood test for pregnancy, what do they look for? Oh, Izzy, great question. So they look for HCG levels. So when you, so they look, so if you're doing a P test or a blood test, they'll look at your HCG levels first and foremost. With blood tests, you can also look at other levels. So from a blood test, you can look at HCG, you can also look at progesterone, you can look at estrogen, and you can get a better, a more complete picture of what those levels actually are. With the P pregnancy test, it's just, is HCG there or is it not? Or is it there in a large enough quantity to be detected by the test, or is it not? With blood tests, they can say, yes, not only is it there, but it's there and it's this particular level, which is appropriate based on where we think you are from a pregnancy standpoint, which is mostly determined by looking at the first state of your last menstrual cycle. That's a good question. So the placenta, some other things about the placenta, it begins to develop around the second week once implantation of the blastocyst is complete. But again, it's not, the placenta isn't functional until about week 8, week 9. Well, actually, I should say week 8 to week 12. You don't see the corpus luteum really deteriorating until week 12, but the placenta starts to be functional around week 8. Oops. Okay, so the placenta itself, of course, is going to have fetal and maternal components because the placenta is just the way we define what the placenta is where it's the junction of where you get maternal and fetal circulatory systems coming into contact with one another. When we look at the placenta itself, so this is showing you an embryo, right, that's developing, and you'll see that there are these vessels that are coming out and there are these kind of finger-like projections. These are called the chorionic villi. And what you're seeing here, this is, again, this is the developing placenta. So you can see here just how and what kind of proximity fetal blood supply comes into contact with maternal blood supply. And it's very, very close proximity. And so these chorionic villi are, they are the fetal component, or they contain branches off the umbilical cord. So they contain blood vessels involved with fetal circulation. And so these have been, they're clinically relevant because if during a pregnancy, and this situation has changed somewhat just in the last, definitely the last 10 years, but probably the last 15 years, because with the advent of other ways to look at fetal DNA. But let's say 25 years ago, before they had the test where they could just do a venipuncture, a maternal venipuncture, and harvest fetal DNA from maternal blood. Before that occurred, in order to test fetal DNA, you had to access fetal blood. And the only way to do that would be through chorionic villi testing. So, and accessing the chorionic villi poses an inherent risk to, or it is associated, I don't know statistically speaking, but it's associated with causing miscarriage, or can cause, I should say, miscarriage. So chorionic villi testing used to be done if, for example, after an ultrasound, if there were what they call soft markers that were noticed, which are just kind of loose and soft markers. Let me see, how else can I couch this? Soft markers meaning indications that something might be anomalous with the developing embryo, although not at all a hard and fast. Well, there are lots of times you get the presence of soft markers and there's nothing wrong with the embryo. But if soft markers are detected, what can still be done is you can go in and you can sample DNA through the chorionic villi, and you can get information from a chromosomal standpoint about the fetus, or I'm sorry, about the embryo. And you can do this in a timely enough fashion that if the condition that is detected with the developing embryo is not something that's maybe going to be compatible with life, there are options for that pregnant woman with regard to whether or not she wants to continue the pregnancy. Now what can be done, and it can be done even earlier and less invasively, certainly, than chorionic villi sampling, is, as I was just making mention of, a maternal venipuncture, and they can now harvest enough fetal DNA to do a karyotype, which is when you look at the cells and you make sure that you have 23 copies of each one of your 23 chromosomes and 2 copies of each. So like I said, that's something that is just as kind of a recent advent to medical technology when it comes to monitoring pregnancies. Okay, so kind of just more information on the placenta. We talked about how the placenta allows for communication between the maternal system and the system of the developing structure embryo to fetus. The placenta is what's considered a selectively permeable barrier, meaning that it does prevent a lot of substances from gaining access to that the maternal system might come into contact with, from getting into fetal or what will the structure's circulatory system. But it's still permeable, right? So the implications of that are that there are certain substances, especially substances that are small and nonpolar and very tiny things, substances such as viruses, that are able to leave the maternal system and get into fetal circulation. And often, or not, maybe not oftentimes, but sometimes those substances can cause damage to the developing structure. If they are substances that can cause damage, we call them teratogens. And teratogens, viruses can be teratogenic, medications can be, there's lots of things out there that can be teratogenic. And we'll talk here in a moment about organogenesis, which starts around week 3, which is a period of time during which a woman might, and oftentimes doesn't even know she's pregnant if she's not looking for it. But exposure to teratogens, especially during this very kind of critical period of primitive tissue formation, can be particularly harmful or disruptive to the fetus. And the earlier on, if a problem, if you will, occurs in the pregnancy when it comes to differentiation, the more profound that effect tends to be on the fetus if that pregnancy goes to completion. So this is the rationale behind why if a woman knows that she wants to become pregnant, the advice is to take certain vitamins, because there are certain vitamin deficiencies that are associated with specific congenital defects. It's also why if a woman is trying to get pregnant, she's told to, while she's trying to avoid exposure to teratogens. And teratogens include things that we're commonly exposed to, like, alcohol and, smoking cigarettes and eating sushi because you might get exposed to mercury. All of those things can negatively impact a developing embryo if that embryo is exposed to them. Okay, which brings us to week 3. So at this point, what's happening, of course, the blastocyst has embedded. We now call the structure an embryo, and we call it an embryo because we start to see the differentiation of tissues, which that period of time that occurs between weeks 3 and 8 is what's called gastrulation. Gastrulation happens really early on. It happens during week 3. And what we see during gastrulation is the differentiation of the cells into the 3 primitive tissues, the endoderm, mesoderm, and ectoderm. I want you to know that just in general, the tissues that arise from these primitive tissue types. So the ectoderm differentiates into, amongst other things, differentiates into the nervous system and the epidermis. The mesoderm, think of M as standing for muscle, differentiates into, amongst other tissue types, muscle tissue. I'm just bringing up the ones I want you guys to know. And then the endoderm, think of endo standing for endocrine. The endoderm becomes many of the different endocrine structures we have. It also becomes the lining of the GI tract, and portions of the respiratory tract. So at this point, the structure, I should just mention, at week 3, the structure, week 3 to week 4, and really all the way, I guess, up through week 8, the embryo itself doesn't, it shares similarity. You wouldn't be able to tell if the embryo came from a human or another great ape, or even maybe like an alligator, right? At this stage in development, all the embryos look similar within a particular evolutionary lineage. So if you share up to a certain point, if you share a recent common ancestor with X, Y, and Z species, embryos in the earlier stages of development all look pretty much the same. And that's to say they look like this. But you do get, at this point, you do have the differentiation of the 3 different tissue types. And then into past week 3, so, from weeks 4 through weeks 8. Oh, actually, hold that thought. Let's get through these slides. So these slides just go over those primitive tissue types that we just discussed, the ectoderm, mesoderm, and endoderm. I bolded the tissues I want you to really hone in on when it comes to what these tissues will develop into. So nervous tissue, the epidermis, when it comes to the skin, that's for the ectoderm. Mesoderm, think muscle. Don't worry about these 5 categories. And for endoderm, think endocrine structures, so pancreas, thymus, thyroid. Also think GI tract and portions of the respiratory tract and the urinary tract. So and the reason that's important to know is if you see disruptions in those primitive tissue types that occur, you can to some degree kind of you can determine where you might see the manifestations of those defects showing up. Okay, so past week 3, after gastrulation is complete, we start to see organogenesis. And this is, again, all occurring still during the first trimester. Organogenesis starts at the end of week 3, really, let's say beginning of week 4, and goes through week 8. And during organogenesis, well, the word itself means the beginning of organ development. So that's exactly what's happening. So at the end, I should say, of week 8, all of the rudimentary structures that will become all the organs in your body are in place. You also, at the end of week 8, see the development of things like the arm buds and the leg buds. So although this structure itself doesn't, again, you can't differentiate this structure from many, many other species at this stage in development. Going into week 9, the embryo has all of the structures that will become all of the organs and all of the has all the rudimentary structures in place that now just are going to undergo further development. Right. And so again, that kind of concludes week 8. So by week 8, let me back up 1 second. At week 8, we have a structure that looks roughly like this with all of the organs, the rudimentary organs in place. We have differentiation into the head and the tail region, if you will. And then what happens during the fetal period, which begins at week 9, is you get further differentiation and further development, and then growth. Is kind of the hallmark of the fetal period. So the fetal period goes from week 9 through week 38. And we call this structure starting at week 9 a fetus. And there's some political implications. Sometimes it's really not called the fetal period until week 12, after week 12, but we're kind of going with just the textbook definitions for this. So fetal period, week 9 through week 38. And again, what you see during the fetal period is growth, especially so we break pregnancy into trimesters. We have the first 12 weeks, during which that's where you're going from embryo to fetus. During the second trimester, we see a lot of changes that occur to the maternal system in preparation for birth. And then during the third trimester, what you see is growth of the fetus and the deposition of basically preparation for that fetus to be able to exist and to do things like thermoregulate outside of the womb. So, growth in size, deposition of subcutaneous fat, development of hair, all of that occurs in kind of the late second trimester through the third trimester. And there's a lot of growth because of that increase in subcu fat and growth in length of the fetus. It's during the third trimester that you typically see the baby bump, so to speak, becoming very, very prominent. Okay, I'm gonna not spend a lot of time on here, just kind of suffice it to say, that many times when fertilization happens, the person doesn't even know that that's occurred, because they say somewhere around 50% of the time, fertilization or so pregnancy results in what is called spontaneous abortion, um, which is just to say the woman goes through a menstrual cycle and doesn't even know that person doesn't even know they're pregnant. And most of those spontaneous abortions occur because of chromosomal abnormalities. So when chromosomal abnormalities exist, most of the time, the chemical signals sent by that developing structure communicate to the maternal system, and help to basically change hormone profiles in a way that do not support pregnancy. I'm also not going to spend a lot of time at infertility. Just kind of suffice it to say, infertility, there's a variety of different underlying etiologies that can cause infertility, both on the maternal and paternal side of things. And so, yeah, that's kind of all I'm going to say about that. Trimesters. So, as I was just mentioning, pregnancy is broken into trimesters. So we have the first 3 months, we have the second 3 months, months 4, 5, and 6, and then months 7, 8, and 9 in the third trimester. And first trimester is really marked by this incredible differentiation that occurs in what was the blastocyst and then became the embryo, and then organogenesis, all the way up to the fetal period. During the second trimester, what you see is continued growth of the fetus, and then a lot of changes, as I mentioned, that occurred to the maternal system in preparation for delivery. And then the third trimester, you see further preparation of the maternal system, in addition to not a lot of differentiation that's occurring during the third trimester to the fetus, but growth to the fetus. So at the end of the second trimester, the fetus looks and has kind of all the structures in place that you would associate with a newborn, but that fetus is very small. And I mean, this situation changes based on technology, but I think by and large, still pregnancies that result in delivery before the 24th week of gestation tend to be kind of touch. I don't know what the stats are, but tends to be difficult to keep the fetus alive if birth occurs before 24 weeks, just because the fetus is so small and is not yet prepared, hasn't gone through things like maturation of the lungs and the changes that equip the fetus to be able to survive outside of the womb. Okay, and then when it comes to endocrinology, right, I do want you guys to know these hormones and what they do with regard to the maternal system and how that helps to support a pregnancy. So, as we have already talked about, the placenta, after the first trimester, the placenta becomes the endocrine structure that is temporary endocrine structure that is there to support the pregnancy. So that's what the placenta does, in addition to allowing for communication between fetus and maternal blood supply for things like nutrients and gases. The placenta secretes a lot of hormones. So amongst those are estrogen and progesterone. So estrogen and progesterone levels during pregnancy remain high and just continue to get higher and higher. As we started out talking about, high levels of estrogen and progesterone suppress FSH and LH, which is really important and is the basis why, if you are pregnant, why you cannot get pregnant with other oocytes. You won't ovulate during pregnancy, which for maybe not so obvious reasons is really important. I mean, you wouldn't want to be pregnant and be 3 months into a pregnancy and then get pregnant with have a fertilization of a secondary oocyte and have pregnancies that are at different developmental stages. That wouldn't be something that would be compatible with propagation of your species, right? So having those really high levels suppresses ovulation, so you don't get pregnant again while you're pregnant. It also, estrogen and progesterone levels high estrogen and progesterone do things like cause the uterus to become larger, cause increase in mammary gland activity and enlargement, so the breasts become larger. Estrogen and progesterone are required to support fetal growth. So if those levels aren't high enough, you don't get adequate growth of the fetus. Mm. Progesterone in particular is also the hormone that's responsible for causing relaxation of the ligaments, which is kind of counterintuitive because there's this other hormone right here called relaxin that was initially thought to do this. So during pregnancy, a woman's ligaments become very, very loose. And that is so that during the birthing process, the pelvic girdle can essentially separate to allow for the head to make its way down the birth canal. So, and because it's progesterone, because it's a hormone that causes relaxation of these ligaments, it's not exclusive to just the ligaments of the pelvic girdle. You also see relaxation of ligaments in the feet, which is, and what that causes, along with the weight that causes kind of collapsing of the arches. But what that relaxation does is it allows the bones, the phalanges, and the metatarsals, and I guess mostly metatarsals and phalanges to spread out a bit. And so, and they never go back to their original size, if you will. And so this is why when for many women after pregnancy, their feet are a size bigger, is because of the effect that progesterone has. Relaxin was given the name relaxin because it was thought initially to be the hormone that was associated with relaxation of the ligaments. We now know that that's progesterone. Relaxin is also secreted by the placenta and the corpus luteum before the placenta. And what this hormone does is it promotes blood vessel growth in the uterus. CRH, which is corticotropin releasing hormone. So when you see this hormone, your brain should automatically go to the hypothalamus because that's where the releasing hormones come from. But the placenta is also capable of secreting CRH. And what CRH does in the context of being pregnant is it plays a role in things like timing of childbirth. It also causes, CRH causes in general, whether it comes from the placenta or the hypothalamus, it causes aldosterone to be secreted from the adrenal glands. And aldosterone causes us to pull sodium back into the blood at the level of the kidneys, waterfalls sodium. So CRH is responsible for this increase in blood volume, which is so critical to supporting a pregnancy because because that essentially that blood is being used to supply a developing embryo and fetus with nutrients and gases, et cetera. You need a greater blood supply. So having a greater blood volume increases the blood pressure, which is going to increase the rate at which that blood is delivered to fetal circulation. It also, CRH levels can, or this, I should say from a clinical standpoint, CRH can play a role in, so having a homeostatic imbalance that some women experience toward the end of pregnancy is a condition by which blood, so pregnant, what they call pregnancy induced hypertension, which can result then in preeclampsia and eclampsia. Those conditions are tied to CRH. So if CRH levels are, which they are during pregnancy, very high, and for a variety of different reasons, if that the female, the maternal system is not able to kind of accommodate this excess blood volume, that can cause that woman to have really high blood pressure, which really high blood pressure compromises both the mom and the fetus. That's kind of an aside, but it's, so CRH is associated with things like edema, which is really common, especially toward the end of pregnancy. Human chorionic thyrotropin. So thyro should remind you of thyroid, right? HCT is the acronym. This is also secreted by the placenta. And what this hormone does is it increases, it stimulates the thyroid gland and therefore it increases metabolic rate. So increasing metabolic rate will increase both things like cellular turnover. It'll increase the rate at which ATP is produced. It'll increase many of the effects that are seen in pregnant women are due to this increase in metabolic rate. And by many of the effects, I mean things like increases in blood pressure due to increases in heart rate and increased respiratory rate, et cetera. Those are all tied into HCT levels. the placental lactogen hormone, so HPL, also secreted from the placenta, plays an important role in how the pregnant woman metabolizes macromolecules. So the effect HPL has is it does things like it makes the pregnant woman's cells resistant to insulin. So the effect that that has is to keep blood glucose levels higher than what you would normally see. And that allows there to be more glucose available to the developing embryo and fetus, right? That can also contribute to the development of a homeostatic imbalance called gestational diabetes. Um, HPL also allows the pregnant woman to use other macromolecules more efficiently to make ATP. So pregnant women can utilize fatty acids more efficiently than non-pregnant women. Um, like I said, it importantly increases blood glucose levels, so it makes more glucose available for embryo and fetal growth. But like anything, if that goes awry, or if that doesn't stay within the realm of homeostasis, it can be problematic both for the developing fetus and for the mother. Gestational diabetes results in babies that can be so large that cesarean sections are required, that vaginal delivery becomes compromised. And obviously for the pregnant woman, being diabetic is not good for her tissues. Okay, prolactin. So the acronym for prolactin is PRL, and prolactin is a hormone that is not secreted in high levels during pregnancy, but levels skyrocket right after delivery of the fetus. And what prolactin does is it causes milk production. And then oxytocin, the next hormone on this list, oxytocin does a bunch of different things. So oxytocin is made by the hypothalamus, but it's stored and secreted by the posterior pituitary gland. And what oxytocin does in the context of being pregnant is it causes, very importantly, it causes powerful uterine contractions that are associated and required for vaginal delivery of the fetus. Oxytocin is required for ejection of milk from the breasts after the fetus is delivered. Oxytocin also, in a variety of contexts, is kind of considered like a love hormone, or it encourages bonding behavior. So oxytocin levels spike during delivery and then remain high after delivery. And so you can theorize that these levels, because newborns through, really infancy, are so dependent on caregiver attention that a newborn can't survive on its own. A newborn human can't survive on its own. And so you can theorize that having these high oxytocin levels also promotes the bonding behavior that makes the woman who just gave birth feel very, feel responsible, and therefore kind of increases caregiving behaviors, and would in that case, therefore promote the likelihood that that newborn would survive. Okay. And then melanocyte stimulating hormone is also secreted from the placenta. And this hormone causes an increase in melanocyte activity and is responsible for phenomenon that occur during pregnancy that include darkening of things like the areoles. So the areola during pregnancy become much darker. Newborns are born mostly blind. They can see shades. And so having a dark areola makes, during rooting, which is the phenomenon where the newborn is looking to latch to the nipple, having the areola be dark allows the newborn to kind of visualize where it needs to latch more effectively than if that weren't to occur. And then there are other kind of, that increase in melanocyte stimulating hormone also is responsible for things like the development of melasma, which is a skin condition, or just the darkening of skin in general in certain areas. Okay, so I'm not going to spend any time on this slide because I said everything I want to say, right? I do want you to know that pregnant women in general are resistant to insulin to a much greater degree than non-pregnant women. Again, that's in order to keep blood glucose levels high for the developing fetus. And then the hormones that are associated with pregnancy also can have some less desirable side effects, as morning sickness being one of them. We don't really know why certain women experience morning sickness and other women don't. We do know that it is hormonally dependent. Um, and then probably due to specifically estrogen and progesterone, but that's still kind of being teased out. High levels of progesterone can also cause unintended, undesirable side effects, like things, which would include things like constipation. Or progesterone kind of slows down GI movement in general. And so mm, it can, again, produce some kind of undesirable uh, side effects in women during pregnancy. And then when it comes to nutrition, so most of the weight gain that takes place during pregnancy is due, of course, you have this increase in blood volume, increase and growth of all of these tissues that are associated with the pregnancy, not the least of which includes the fetus itself. And then pregnant women deposit adipose tissue more rapidly. And that is presumably because being pregnant and giving birth, and certainly producing milk to feed that newborn, is something that is very energy expensive, especially the lactation process to the pregnant woman and then the nursing mother. And so having kind of some extra adipose tissue increases the likelihood that if that woman were pregnant and were to go through a period of starvation, she might still be able to sustain a pregnancy and still have enough adipose tissue to support the metabolic needs associated with lactation. And then we're not going to talk, if you go on and take other classes in pregnancy, you'll talk a lot about specific requirements when it comes to nutrition and the effects of various vitamins, for example, on pregnancy and the developing embryo and fetus. But just suffice it to say right now that the B vitamins, so folic acid, is something that is folic acid, iron. These are vitamins and minerals that play an important role in supporting the pregnancy and then also in helping to prevent specific types of defects that are associated with, I'm kind of particularly referencing folic acid, but there are what we call congenital defects that are associated with not having enough folic acid that specifically are typically related to nervous system development. Okay, gestational diabetes, we've talked about. It's a homeostatic imbalance related to being pregnant that predisposes the pregnant mother to developing type 2 diabetes later on in life. And it's characterized by having abnormally high levels of glucose. So you end up with fetuses that are really well fed, so to speak. So they tend to be larger in size. And then, of course, diabetes is not a condition that's healthy for the pregnant woman. Hyperemesis gravidarum, I'm not going to test you on, but it's another homeostatic imbalance that women who develop this condition basically have, I guess worst case scenario, uncontrollably vomit throughout the course of pregnancy. So that morning sickness phenomenon, which is typically kind of specific to the first trimester, people who have hyperemesis gravidarum, it lasts throughout the duration of the pregnancy and can be so problematic that a pregnant woman has to spend at least part of her pregnancy in a hospital getting IV fluids, because dehydration, of course, if you are vomiting, can dehydrate you really quickly. And then when it comes to changes in the cardiovascular, respiratory, urinary systems, what I want you to know for the pregnant mother or pregnant woman is that you see blood volume goes up by about 50%. So in order for most people, if your blood volume went up by half, right, that would make you so hypertensive that you would possibly kind of immediately stroke out. That obviously doesn't happen with pregnant women often, and that's because in addition to increasing blood volume, the hormones associated with pregnancy cause vasodilation. So you get that pregnant woman has the ability most of the time to accommodate this increased blood volume by having her vessels dilate. And so that's an important phenomenon that occurs. That's why, in fact, you see when somebody is pregnant, usually in the beginning of pregnancy, blood pressures drop because you get this vasodilation. And then for some women, especially in the third trimester, that increase in blood volume can result in a pregnancy-associated type of hypertension, which at the very extreme ends of things can cause what's called eclampsia, which is where the blood pressure for the pregnant woman is so high that the glomerular filtration rate is so fast that you find things like proteins in the urine. You're spilling things that normally would be reabsorbed into your urine. And the blood pressure, if you're eclamptic, can be so high that it can cause seizures and death. The only cure for pregnancy-induced hypertension, whether it just be the hypertension, but all the way through eclampsia, is delivery of the fetus. And that's because the hypertension is specifically due to the hormones associated with being pregnant. And then for the respiratory system, as I mentioned earlier, a woman who is pregnant has a faster than normal respiratory rate. So that individual will have lower CO2 levels compared to what they would have if they weren't pregnant. And that helps to facilitate the removal of CO2 between fetal circulation, or helps to promote diffusion of fetal CO2 very quickly into the maternal blood supply, so that the maternal blood supply can get rid of that excess CO2. It also, having a faster respiratory rate, pulls in more oxygen, so it makes more oxygen available to the developing embryo and fetus. The kidneys, of course, because you are increasing blood volume, the kidneys have more blood that needs to be filtered. So being pregnant is taxing on the kidneys. You can see an increase in filtration rate, which is not surprising because you've increased blood volume. Pregnant women are more susceptible to urinary tract infections than non-pregnant women, because as the fetus grows and displaces, essentially the organs, it's displacing them both up and down and putting pressure in both directions. And so the fetus in the uterus can put pressure on the ureters and compromise removal of urine. Preeclampsia and eclampsia, I just discussed, and so far as much detail as I want you to know, what characterizes these conditions is high blood pressure. And that high blood pressure causes proteins and other abnormal constituents to be found in the urine. And the problem with this really high blood pressure is that it can be so high that it affects oxygen delivery to the fetus. And then if a person becomes eclamptic, one of the characters or characteristics associated with eclampsia is seizure activity. And so that's something that is a medical emergency and requires immediate delivery of the fetus. Okay, so we're now going to move in and we're going to kind of finish up this this material talking about labor. I just want to make mention, Braxton Hicks contractions are non-productive contractions. So contractions that are spaced evenly apart and for a specific length of time are contractions themselves. What they are contractions of the uterus, right? And they're meant to be productive contractions, which are associated with true labor, are contractions that over time become longer in length and spaced more closely together. And that's because the uterus in the beginning is just kind of practicing contracting. And then those contractions get stronger and stronger during true labor in order to facilitate pushing the fetus out through the birth canal. There also are what are called false contractions, and that's what Braxton Hicks contractions are, that many women experience, that are contractions, so they're painful, but they are not productive. They're not causing, and by productive, I mean they're not causing changes to the cervix, because what happens during true labor is as the uterus contracts and pushes the fetus farther and farther down into the birth canal, the head of the fetus puts pressure on the cervix, and that causes the cervix to start to dilate. So when a woman is in true labor and is ready to deliver a fetus, the cervix has to be what's called 100% effaced, and then the cervix has to be dilated to 10 centimeters. And what it means to be effaced is, if you can picture with the cervix in those illustrations, what it looks like is it's really a canal, right? And then as the uterus during pregnancy, as the uterus grows and the fetus grows, the cervix becomes shallower and shallower and shallower, up to the point where when delivery is about to take place, the cervix is so thin that it's basically flat. You basically have the head of the fetus, if the baby is in the quote unquote correct position, the head of the fetus pushing down against a relatively, at this point, thin layer of tissue. And then that pressure causes cervix to dilate. And 10 centimeters is considered the size that is adequate for the head to be able to fit through the cervix, so that the baby can be delivered through the birth canal. Okay, so, and that's what this slide goes over, right? Leading up to labor, estrogen levels continue to increase. The uterus starts to undergo contractions to kind of practice contracting, if you will. And then by the time delivery, when delivery is, during the labor and delivery process, contractions become consistently spaced and of a consistent duration. And those contractions during delivery are actually pushing the fetus down against the cervix to cause dilation of the cervix. And then premature labor is labor that occurs before that 38-week gestation, which it's 38 to 40 weeks, depending on how you calculate it. 40 weeks is the way it's typically described, because when a pregnancy is calculated, you'll be asked to report the first day of your last period. And if you can remember back to when we started this PowerPoint, it takes about 2 weeks from ovulation through implantation. And so that 2 weeks is what's kind of accounted for when they give the 40-week estimation. But it's 38 weeks from the time the blastocyst is embedded and begins to develop into the embryo. And before that, in premature labor and delivery is problematic again, because the fetus, depending on how premature it is, might not be ready for to exist outside of the womb. Okay, and then we'll finish up, you guys, with this slide. And here's what I want you to know about labor and delivery. So labor, delivery, and for that matter, breastfeeding. So I guess let me back up. Endocrine loops are most endocrine loops are controlled using negative feedback, right? Which is this vacillation around a set point, and any deviation from that set point essentially turns a system on or off so that you circle back to that set point. So kind of think of like a thermostat set at 68 degrees. And if the temperature, ambient room temperature goes above 68, that kicks on the AC. Temperature goes back to 68, AC kicks off. If the temperature drops below 68, like it does in the winter, furnace kicks on, brings the temperature back up to 68, furnace turns off, right? That's negative feedback, kind of in a nutshell. Positive feedback is different, very different, because with positive feedback, there's no set point that you're kind of vacillating around. With positive feedback, what happens is that until you remove the stimulus, the feedback loop continues, and it happens, it increases, I suppose is what I'm trying to say, in strength, or it increases in robustness. So in the context of delivery, right, what you see is you start with the control center. So the control center is going to be the hypothalamus, both for the fetus and for the pregnant woman. And when a woman is ready to deliver, the hypothalamus, both from the fetus and from and the hypothalamus of the pregnant woman, start to secrete oxytocin, right? That oxytocin causes the uterus to contract, and it also stimulates the placenta to secrete prostaglandins, which are a class of what we call eicosanoids, which are locally acting hormones. So the contractions of the uterus, along with the prostaglandins, or I should say the oxytocin, along with the prostaglandins, cause the uterus to contract more and more with greater and greater strength. Having the uterus contract pushes the fetus down and pushes the head against the cervix, and that causes the cervix to dilate. And then that dilation cross-talks back with the hypothalamus and causes even more oxytocin to be secreted, right? So as you can see, as the fetus pushes kind of harder and harder against the cervix, you get more and more oxytocin being secreted, which causes stronger and stronger uterine contractions up until the point where the fetus is delivered. And then the delivery of the fetus stops the process by which the hypothalamus secretes large amounts of oxytocin. And also delivery of the fetus, the fetal hypothalamus, the oxytocin that is being produced by the fetal hypothalamus will no longer enter maternal blood supply. So oxytocin levels drop dramatically and the uterus stops contracting. Right. So that's kind of the take home with labor and delivery. Is it's the oxytocin and the prostaglandins that work together to cause uterine contractions. The uterine contractions push or kind of force the fetus farther and farther down into the birth canal, or force the fetus to put pressure, the head, in this case, if the baby is positioned head down, against the cervix, and that causes dilation up until the point where if someone is finally at 10 centimeters, the fetus can be delivered through the birth canal. Okay, you guys, so that's where we're going to stop. I'm not going to test you. Oh my gosh, and we're out of time. Sorry about that, you guys. Jeez, I talk a lot. So yeah, so that's it. And that's where you'll be tested. That's the point up until you'll be up until when you'll be tested. Okay, so I'm going to stop the recording. I will post this along with the other PowerPoint on our Canvas course site tonight. So you'll have access to these that way. And I will open the test tomorrow, probably mid-afternoon, maybe early afternoon. And I will leave it open all through next week up until next Friday at 11:59 p.m. And just by way of reminder, all points are required to be submitted by 11:59 p.m. on the 17th. Okay.